This is, of course, a very interesting topic, and I actually ended up sending Katharina a chat. What do you want me to talk about? It wasn't really clear for me, so how I chose it, and Katharina told me what she would like. So I have based this on mostly one case, and it will be very interactive. So you all need to follow, because I will ask you questions, and I need hands. And then you get the answers later on. So here are my disclosures. And I also would like to say that my major disclosure is of working very tightly with Katharina and Bruno Crestani and Oliver Dissler and Venerino Puletti and some others here on the ERS-EULA guidelines for the management of CTD-ILD. And you will understand during my talk why I mentioned this as a conflict, because I will show you some of the data from the ACR chest guidelines, which once these are published, and these are under embargo, so we're not allowed to talk about, but you may find some differences. So, and you may find that I sound a little bit skeptic against the ACR chest guidelines. So this is why I thought. So let's start with a patient. He is male, was born in 1969, Caucasian, non-smoker, had a little bit of high blood pressure. Otherwise, he was normal BMI, no other comorbidities. He developed quite quickly Raynaud's phenomenon in September 2017. His first non-Raynaud symptom was in December 2017. So that was a very quick from Raynaud to first symptom. He very quickly developed skin disease. He had a rotten skin score, which you all know is when you pinch and punch the skin of 31, which means that a lot of the skin was already involved. He had a positive ANA with anti-RNA polymerase III antibody positivity. He had some inflammation with increased CRP and ESR, no other organ involvement such as renal or GI symptoms or tendon friction rub or ulcers. Regarding the lung, he did not have any dyspnea, no cough. He had a normal 6-minute walking test, no desaturation on 6-minute walking test, a little bit limited and restrictive pattern on lung function with FVC, FEV1 of 77%, DLCO of 66%. So my first question to you is, would you screen this patient for ILD using HRCT? So the ones who say yes, please raise your hands. Okay. The ones who said you would screen but not use HRCT? None. No screening at all? None. I'm not sure. Okay, I love you guys. So this is pulmonology. Of course, we would all think this patient, regardless, should be screened with HRCT. We all agree. Now we get some challenges, because the ACR chest guidelines say that we should only screen patients with a rheumatic disease who have risk factors. So they say this for all now. So they say even systemic sclerosis, which is a rare disease where the prevalence of ILD is high, they say only if the patient has a risk factor, refer this patient to screening with lung function test and HRCT. I will show you some challenges with that. Then they conditionally recommend against using chest radiography. We all would agree that's okay, of course, 6-minute walking test, desaturation, bronchoscopy, and they strongly recommend against surgical lung biopsy. So now let's go on back, because now these the guidelines say only screen patients at risk. And now I hope you listened when I presented you the case. Does this patient have risk factors for ILD? So yes. Who thinks yes, there are several risk factors? Okay, thank you. No? No one? I'm not sure. Okay, again. And of course, I agree with you. So the risk factors are he's male, he has short disease duration, he has diffuse skin symptom, he has inflammation, all risk factors for ILD. On the other hand, he is asymptomatic, he has a bit reduced lung function, but nothing major like this. But then on the other hand, he also has risk factors against ILD. He was not a smoker, he's a Caucasian, which I forgot to highlight. He has polymerase III, RNA polymerase III antibody, which is usually not associated with ILD, no tendon friction rubs. So let's look what the ACR chest guidelines say. So these are the risk factors they will include. It's not published yet. They showed it at ACR. So these are the risk factors they published. So anti-topo, he didn't have. Diffuse, yes, he had. Male 6, yes. African American, no. Early disease, yes. Elevated acute, yes. So that would, of course, clearly be a patient which we also would have screened with HRCT in practice. But the challenge is, when we looked at, now I need to tell. The challenge is that not all patients do have risk factors. And what we did with the Norwegian cohort, we looked at our patients with SSC-ILD, and we are very lucky in Norway. We can refer everyone we want to HRCT, and of our systemic sclerosis population, 95% are referred to HRCT and have an HRCT. And when we looked at our patients, we actually identified that in the presence of ILD on HRCT, 25% of the cases don't have a single risk factor for ILD. So that means if we really adopt now these ACR chest guidelines, we will lose 25% of patients with ILD who will not be identified because they will not be referred to screening. And that is, of course, something which we all want to avoid. And then I had a colleague from Romania in Norway for half a year, and she's coming from a country where it's not possible to refer everyone to HRCT. They have a strict health policy, they have insurance problems, so they actually use a risk factor-based screening approach. And here you can see the patients which she had screened in her cohort, they all were enriched for these risk factors. The problem is then we wanted to see how many patients do we lose in her cohort. And of course, we don't have a follow-up HRCT, so we cannot say that they have definite ILD. But what we did is we said that if they have an FVC decline more than 10%, it's probable ILD. And when you look here in her cohort, can you see the mouse? No, I needed to click somewhere. Nope, sorry. Oops. No, I'm going wrong way. Okay, sorry. So what we did is, I was instructed how to use the pointer, but I don't remember. So what you see in red is the patients from a Romanian cohort who did not have HRCT in light red. 50% or 55% of these had an FVC decline more than 10% over a year. So this means that most likely, based on the risk factor approach, you would even miss even more patients having ILD than in the Norwegian cohort with 25%. So this really means that imaging is important for screening of rheumatic diseases, and especially in systemic sclerosis. It seems feasible to refer all patients because it's a rare disease. It's not many patients in every country. So back to our patient. Here we got a HRCT, and as you all can see, he had interstitial lung disease, not very surprising to all of you. And here you can see the lower lobes. So we did start him on mycophenolate based on that he had massive skin disease and some ILD. And this is just a quick reminder, a new meta-analysis published last year, where they looked at 283 publications based on prevalence of ILD in systemic sclerosis. And here you can see that the prevalence in systemic sclerosis, myositis, mixed connective tissue disease is all high, varying from 50 to 70%. But then, of course, we do have some problems looking at rheumatoid arthritis, which is the above one, which is a prevalence of less than 10%, and Sjögren disease, which is about 15%. So these patients, of course, using imaging for screening or referring all to HRCT might be a challenge. And there, of course, there is a lot to do for all of us. And remember that if you do screening in these patients, publish your work, because we need to understand how we should screen these patients. And there's a new modality which is lung ultrasound, and I know a lot of you pulmonologists are doing already lung ultrasound. And this is, of course, something we should discuss. Is lung ultrasound something which we could use in RA and Sjögren's disease, an example, to look who to refer further to HRCT? And there was a very nice study which was from Wim Weitz from Leuven and his PhD, which was presented now at EULA. And they looked at 109 patients who were screened with lung ultrasound, HRCT, lung function test, and respiratory symptoms mapping. And what they found is that there was a very strong correlation between lung ultrasound, which you can see here. I think I really need to understand how to put the pointer on, if someone could help me. Maybe it's here, right? Here we go. Perfect. Now I understood. So here you can see that there's a strong correlation between the HRCTs and B lines on lung ultrasound. There are also correlations between HRCT and DLCO. There's no correlation with with FVC and respiratory symptoms. So this is also telling us that screening patients just based on FVC or lung symptoms is not good enough. We do need some imaging. And here again, we need some more data on lung ultrasound, whether this is the future, but at least these data here are already very convincing, and we have lots of other data. So back to our patient, which came back to us in April 2018. And that time point, he had really increasing progressive skin disease. So he had increased his Rodnan skin score from 31 to 42, which is a lot in such a short time. And but other than that, for his lung, he was stable. So now it's a question to all of you, and I know you're not rheumatologists, but what would you do now? So this patient has rapidly skin disease, but is stable in their lung. Would you continue with MMF? Get up your arm. No. Who would switch to cyclophosphamide? Menrino, wake up. Switch to rituximab? Oh, no. Switch to tocilizumab? Okay, there we have some. Nintedanib? No. Other. Okay, so no one really knows. It's a bit versus tocilizumab. Perfect, thank you. So what we did as rheumatologists, we considered stem cell transplant. This is something which we do in very few cases in Norway, but we considered him. And he was also accepted for a stem cell transplant, which he received in June 2018, and we kept him on mycophenolate. So he came back in September, a couple of months later, and he was still fine in his lung. You see lung function test, maybe a little bit of decline, DLCO clearly some decline, also skin disease much improving, still no tendon friction rupts. You see his lungs still fine. And then he was admitted for respiratory worsening in June 2019. And before he comes, just asking, because we talk about imaging, just get him back with some respiratory worsening. Who of you would conduct an HRCT which coming him in as for monitoring? Yes? Okay, majority. Would assess, but not with HRCT, any other imaging modalities? Nope. No screening or monitoring? Nope. Okay. And that is also what we did, of course. But before coming back, I also want to show you what the guidelines say, the ACR test guidelines. And here again, they're saying that for monitoring in general, we should always do an ambulatory desaturation testing. We should do lung function tests. Here they say between 3 to 6 months within the first year in myositis and systemic sclerosis, after they're less frequent for RA, Sjögren, MCTD, every 3 to 12 months for the first year and then less. And here chest HRCT as needed. So this is really something which leaves it open to us, should we use monitoring with imaging or not. And that again is of course something we should discuss also as a community. Do we agree with this, or would we anyway want some imaging also for the monitoring of ILD? They recommend against the use of chest radiography, 6-minute walking test and bronchoscopy. And why are we talking so much about using HRCT as monitoring? And here I want to show you some data again, which we are about to submit now, where we applied the PPF guideline criteria, so the ATS guideline criteria in systemic sclerosis ILD. And what we saw is that the majority of, here 18% fulfilled the criteria. And when you look at the subcategories, why they fulfill the criteria, you see that the majority fulfills it because they're also worsen on HRCT. So 13% FVC decline, HRCT worsening, 6% DLCO decline, HRCT worsening, and here 5% HRCT worsening and worsening of symptoms. So the majority of patients fulfilling the progressive criteria do also worsen on HRCT. So if we don't order an HRCT, then of course we capture much less patients. And this is something we need to discuss when talking about imaging and monitoring. And of course, it's always important to understand, does it also have an impact not only for identifying progressive disease, but also on mortality? And what we found in our study is that it's HRCT worsening which drives mortality in our patients. So it's both the FVC decline, HRCT, but also HRCT worsening are the only factors significantly predicting mortality. So that, of course, all should alert us to really be more active also in using HRCT as imaging in the monitoring of our patients. So back to our patients, we did, of course, conduct an HRCT as we have very low threshold for referral and we have very good chest radiographers. And of course, he had, I will show you some more CT slices afterwards, but he did have worsening on HRCT. He had an acute worsening of respiratory symptoms, now NIA class 3. He was a 1 before. He has a minor drop in the 6-minute walking test, but a major drop in desaturation. FVC and FEV1 also declining, and especially DLCO declining a lot. So we also conducted a right heart cath in him, and we found also mildly pH with a mean pulmonary arterial pressure of 28. And when we look at his HRCT, you can see here some progression, but not like majorly progressive. So we were a little bit discussing what is causing his dyspnea and acute worsening. But what would you do now when we talk about treatment? So remember, he's only on mycophenolate after his stem cell transplant. So who would continue with mycophenolate? Arms up. No one. Who would switch to cyclophosphamide? One. Who would switch to rituximab? None. Who would switch to tocilizumab? None. Who would add nintedanib? Okay, room full of pulmonologists. And who would assess for lung transplant? Okay, also some. Yes, thank you. So this is what we did. Oh no, first he comes back before we could do, because we referred him to lung transplant consideration, but before we had said nintedanib or lung transplant. And I must say why we didn't consider nintedanib at that time point was that it was not approved in Norway yet. So we didn't have the opportunity to start for other than SSC ILD at that time point. But he came back before we, or at the same time point as we referred him for lung transplant, he came back with an upper respiratory infection. And this was the CT we saw, so he had majorly progressed suddenly. And all of you would have been better for that patient than what we did with not starting nintedanib at that time point. But you can see he also had dropped a lot in his 6-minute walking in the distance. He had still desaturation. You can see his lung function test. He had a major decline. At that time point, every other organ was fine. So he had a treatment efficacy on the stem cell transplant on everything else than the lung. And you can see here also he had like even upper new areas with more fibrotic lung. And he was then assessed for lung transplant. He was not accepted, and that was based on that he had done stem cell transplant. He was still majorly immunosuppressed. And this is, of course, something which I think is important. It's novel knowledge for you. This is why a lot of pulmonologists are fans of antifibrotic patients, also in patients who we think of lung transplant, we rheumatologists don't. And I think this is something which you should know about rheumatologists and working with us, that we are very fond of immunosuppressors and use it until the end. So I think in your MBTs, remind your rheumatologist that that might also be an exclusion criteria for lung transplant. And for that patient, of course, it was a major challenge that he couldn't get referred. And especially after stem cell transplant, some patients never gain their normal immune system back. So then he was admitted because he was so bad under his upper respiratory tract infection. We took him back quite quickly to look at, and then he had even more progress. So he had now a functional class of 3 to 4, FVC majorly declined, DLC of only 15%. So at that time point, even us understood that he had progressive fibrosing ILD, and we started him on nintedanib. And then unfortunately for this patient, he tolerated nintedanib very well. So very sad that we didn't start it before, but at the end, I don't know if we could have saved him. He had several upper respiratory tract infections. We still had him on mycophenolate. I'm not sure that this was needed, and especially with the upper respiratory tract infections. We took a new right heart cath, and he had increasing pressures. So again, also here the discussion again, should we have treated him with something? I don't know. Now he had a wedge pressure of 7. So yeah, so he was at that one time point admitted for another acute respiratory worsening and unfortunately passed away. So that was our case. So I think just take-home messages is ILD is frequently present in our CTDs, and of course we rheumatologists need to do the screening. Just as a reminder, 20% of patients also first have ILD and then develop CTD. I think this is why it's important for you also to have some knowledge about rheumatic diseases and organ manifestation. So assess your patients on a regular basis if you think this might have an underlying CTD but not developed at that time point. I think this is very important from both sides to always look at for ILD or look for an underlying CTD. Screening is important, and here imaging plays a vital role with HSCT. For Sjögren and RA, we need to discuss as a community, when should we do lung ultrasound? Is this something we want to include? And novel definitions of progressive ILD do actually include monitoring with HSCT. With the PPF guideline criteria, we don't capture all the patients who are progressive if we don't have an HSCT. So personally, I think HSCT imaging is important, not only for screening, but also for monitoring, and of course also for treatment evaluation. So thank you very much.